Okay, so hello, good evening, everyone. I would request everyone to please mute your mic and off your camera if it is open. I can see some faces, one to two faces. So I would request everyone to please off your camera as the class is being recorded. So before I go to my further things, I just want to share. I don't know how many of you know me, how many of you are associated with our FSTN, but yes, it's my duty being the academic coordinator and faculty head of FSTN Exploration Foundation. It's my privilege to say something about FSTN. FSTN Exploration Foundation is an ISO certified, MSME approved, Niti Darpan certified, along with that Skill India recognized organization. And we are arranging this type of webinars just every weeks or once or twice or thrice a month, and these seminars or webinars are on different topics, different trends, different varieties, and this is not at all very common. So I hope that will help you a lot. And before going to that, another very important thing, thank you Kushal, another very important thing that you will getting the recording. It's not only the live session, but yes, in the live session it's a very good one to interact with each other. But yes, those who are not able to join, for them also, if you are registering, you are in the group, and you will get the recording after the session. And those who are attending the live session also, it's not possible to remember everything what I am saying or what Shudrita ma'am has said in the previous class. So for that you get the recording. So please give us the time for 2 days. We will update the recording by Wednesday, and within Wednesday you will get your recording, and hopefully within Wednesday also you will get your certificate as well. So not an issue for that, so don't worry about the recordings. You will get the recordings by Wednesday. You will get the recordings, you will get the certificates by Wednesday as well, so don't worry about that. So before I start, I have already given my intro. This is Mrs. Shani Ganguly, Academic Coordinator and Faculty Head of FSTN. Along with that, I am a clinical nutritionist and a sports nutritionist, and also a certified pediatric nutritionist and certified diabetes educator, certified renal nutritionist as well. So I have the multiple degrees, and I have already, like, I counsel a lot of my pediatric patients. So the theoretical part has been taken by Shudrita. I will also take some theoretical parts. Like today I will let you know that what are the practical formula what we use when we are in the OPD, when we are counseling, what type of formulas we generally use, and of course some machines. Like in anthropometric measurement we use some machines. So what are those machines, how do we use? And it is very important to know for a dietitian how to use that infantometer, how to use the stadiometer scale, how to use the MUAC tape, how to use the head to toe meter scale. And along with that, what are the formula we generally use to calculate a very easy way the ultimate height and weight, because it is not possible to carry the NIN book along with you and to know everything from the books. It is not possible at all. So how will I able to calculate? So that today I will tell about the preterm nutrition as well, and something about some diets and some amount. Normal diet chart, it's a generalization, but again I am saying generalization is not a concept. Of course, a concept is individualization. Precision nutrition or individualized diet is a new concept, but I'm giving you a general data that what amount of carbohydrate, protein, fat should be given. So that's thing we can go for. So okay, so already I have talked a lot. Let's start our today's session without wasting much time. So welcome you to the 2 days online workshop on the modern techniques in pediatric diet calculation and nutritional assessment, conducted by FST and Exploration Foundation in collaboration with Amalgam of Benevolent Dietetic Association, West Bengal, India. So ABDA along with FSTN, we are organizing this. And already you have talked about the dietary assessment, growth monitoring, and pediatric nutritional requirement. Today I talk about the how to calculate the height and weight and all, along with that whatever the nutrient energy requirement. Practical case study already Shudrita has taken care of. So I will talk about the preterm nutrition, that is very very important. So generally, whenever we talk about the nutritional assessment and it's talk about the nutritional status orientation, so there is a connection between that. So whatever the nutritional assessment you are doing, it is giving you the nutritional status reporting. So whatever the nutritional assessment you have done for a children, that is ultimately given a picture of nutritional status of that children. Now, to from nutritional assessment to have a picture of nutritional status, this is a clear line. And this line is basically containing some parameters. What are those parameters? First of all, how much food you intake and how much there is loss. That is very important. That how much food is taken by the child and what is the energy expenditure level. That is the one. Then about the biochemical parameters. Now a lot of patients come to me and ask that why for a diet chart making biochemical parameters is important. So if I don't know about the various biochemical level in the body, the level of various enzyme, the level of various hormones in the children's body, how am I able to supposed to know that yes, the person or this children is suffering from that? We are not able to know. So of course biochemical parameters are necessary. Body composition is necessary. Again, a very important thing, body composition. What are the body's carbohydrate, protein, fat level and the various body composition orientation, that is also necessary. Also important, there are functional parameters. So various functional parameters are there, that is also necessary for that part. And various energy expenditure, how much energy is expended through the various activities and functional activities as well. So that is also determined by the nutritional assessment, is also having all these parameters, that is giving a report on the nutritional status, or that is giving a clear picture of the nutritional status. That is ultimatum requirement. So a nutritional assessment is a very structured way to establish a nutritional status and the energy requirement by the measurement. And there are various accompanied by the objective parameter. You are able to understand, is there any specific disease condition like kwashiorkor, marasmus, malnutrition, and what are the treatment needed. Whatever, how we are able to give an adequate treatment for the patient. So this is done by a multidisciplinary setting. The definition of the nutritional status, ultimately we say the condition of the body. As a result, what food we are taking, how the absorption is going on, is there any situation of malabsorption syndrome, and what is the use of nutrition, as well as the disease related factor, how the disease is influencing them. So everything is in the under one roof, is giving the data of nutritional status, that what is the nutritional status of the child, that is ultimately giving a clear picture or a portfolio of it. There is no such golden standard for identifying the malnourished patient or patient at risk. So multiple parameters are being used. Multiple parameters are being used to constitute a representation of nutritional status. First and foremost, it's very, very important to identify the malnourished patient or patient at risk on a proper timely manner, so that dietitian can start their nutritional treatment as soon as possible. So, identification of malnourishment. Is there a patient of kwashiorkor? Is the children is having marasmus? Is the children having malnourishment? So, if the malnourished patient is there or the patient at risk is there, it is very important to determine the malnourished patient or patient at risk, so that dietitian can start the nutritional treatment as soon as possible. And to determine the quantity of malnutrition, so an adequate assessment of the individual nutritional need is also possible to determine the quantity of the malnutrition. So how is the, like, what is the level of kwashiorkor and marasmus? It is mild, moderate or severe. That is also very important to understand. Next, not last but not least, collecting data for the diagnostic purposes. Then we have to monitor the changes in the nutritional status, collect the data for the research, monitor the patient's nutritional status, that if he or she requires a hospitalization or not, and giving the proper diet, giving the proper nutritional adequacy, so that the nutritional assessment is being improved, and the improvement has been done, then it has been increased the nutritional status of the children. So generally, the first stage when a child comes to your OPD, the first is compared estimated requirement. Whatever the nutrient intake, carbohydrate, protein, fat, vitamin, mineral, how much to take and how the people, these children is taking. What is the comparison between that? First, we know about that. Then we know about the clinical sign and symptom. The skin, hair, eyes, the external sign and symptom are there, clinical signs. And there are anthropometry as well, height, weight, circumference, skin fold, that is also there. So external sign is there, skin, hair, eyes, hair, skin, hair, eyes. These are the clinical signs which we have. And clinical signs, basically we are able to understand if the child has come, and the child having a pale yellow sclera of the eyes, and there is brittle nails, and there is colyonchia at the spoon shaped nails, and there is paleness at the face, cracking of the lips. That is ultimately the sign and symptoms of anemia. We are able to detect it only through by our visual examination. That can be done. Then we can go for anthropometric measurement. Anthropometric measurement is height, weight, circumference, skin fold. We are able to measure the height, weight, circumference, skin fold, and many more things. So this is also very important. When a child comes to the OPD, it's very important to take the head circumference, chest circumference, skin fold measurement, height and weight. After the preliminary detection, if we detect anemia, after this preliminary detection, the first stage assessment, we go for second stage assessment. That what are the biochemical parameters? To know about the hemoglobin level, hematocrit value, to know about the blood volume, to know about the WBC profile, platelet count, everything we are able to understand with the second stage assessment. Also, we are able to understand with the blood or urine test for the protein status and vitamin, mineral, trace element, etc. Also, we have to know for an anemic child, we also have to know about the protein level in the body. That can also be understood, and also the level of vitamin, mineral like iron level, vitamin C level, that we are able to understand through an anemic children profile. Now, after that assessment, we go for the third stage of assessment. That is completely on how the body fat is distributed. That is done by various meters is there, various DEXA, that is a measurement machine through which we are able to determine the body composition level. And then we go for various developmental tests, neurological function tests, and many more like this. So, anthropometric, biochemical, clinical, and dietary assessment is there, and that has already been taken by Shudrita. So, now it's time for knowing about the anthropometric measurement, how we are taking. Of course, height, weight, mid upper arm circumference, that is this circumference for the children, demispan or arm span, their knee height, their sitting height, their skin fold thickness, and head circumference, chest circumference to be taken. So I hope this machine you know, and you should know as a dietitian, you should know about this weight machine. So this is called the spring balance or beam balance, and there is also a digital infantometer is also there. So these are the various, this is a baby salter type machine where you have to just hold the child, and there is a circular weight machine through which a bag is hanging. You have to keep the child on this bag, and the circular weight machine will give the weight according to the proper scale. The scale will be there. So this is like a swing balance or spring balance machine or beam balance machine. And there is also digital meter which is available in the hospitals. You have to keep the baby on that, and the baby's weight will be digitally available. So that is ultimately we call the infantometer. So these are the articles we need to know when we are going for a pediatric OPD. It is very, very important. Okay, so this balance you are using, and that are like for those, sorry, like those who are able to stand 3 or 4 year old child, for them we use it. And for we use this, and for the infants we are using this infantometer. Now coming the Witt's formula. That is the formula we use in the OPD. So don't you have to write. You don't have to write because you will get this PPT. So don't worry about that. So 3 to 12 months there is expected weight, generally age into months plus 9 by 2. Generally if the age is 10 months, so 10 plus 9, 19 by 2. So that is around, if a 10-month child should have a 9.5 kg of body weight. Okay, so in that way we are able to understand. Okay, uh, just a second. So 3 to 12 months, there is expected weight is equal to age into months plus 9 by 2. So generally, if a 10-month-old child, it is 10 plus 19, 19 by 2, it's generally 9.5 kg is the body weight. So these are the formula which you can use in OPD, that what is the expected weight and the OPD patient who has come to you, what are their weight. So you are able to understand like the body weight should be 9.5 kg and you are seeing that the weight is 8 kg. So ultimately you are saying okay, slightly lower but it's all right. But you are saying it's 5 kg. So ultimately very lower body weight. So in that way we are able to go for this. This is how we go for expected weight. Now for 1 to 6 year old children, expected weight is equal to age into 2 plus 8. So if the weight is 5, if the age is 5-year-old children, so 5 into 2, 10, 10 plus 8, 18. So that is the ultimate weight we can go for. Expected weight is equal to age into 2 plus 8. That means if I go for 8 into 2, 5, if the age is 5-year-old boy or a 5-year-old girl, 5 into 2 plus 8. So generally 10 plus 8, 18 kg. So general expected weight is 18 kg. For same for 7 to 12 years, expected weight is equal to age into 7 minus 5 by 2. So generally, if I go for age into 7 minus 5 by 2, so if I go for a children of 10 years, 10 into 7, 70, 70 minus 5 is equal to 65, 65 by 2 is generally 32.5. So generally the body weight should be 32.5 or 33 for a 10-year-old child. Accordingly, that through the Wheat's formula, we are able to understand that what is the expected weight. You on the OPD, you just calculate it very easily. You don't have to see any chart from the internet, or you don't have to see the book. So these are the formula which we use in the OPD department for the pediatric calculation to know about the expected height and weight. That is the ultimatum we use. So now we come for the stereometer. I hope you have learned this scale. This is a stereometer and this is the infantometer for the height measurement. So this is the infantometer to measure the height or length when the child is being sleeping and when the child is being kept here through the sleeping mode, and the foot port is being given at the back of the sole. And this is a stereometer which we are measure the height of a preschool age and adolescent, and also for us it is like giving the head measurement and what is the amount you are able to see in this stereometer scale. So that are the stereometer we are using is for height measurement. So how you can see, this is for a big boy we are using. See, this is like how you are lying down and your head should be when the child is lying down. This is for the newborn who are not able to stand, and for the infants who are not able to stand properly, for them we are using it. You have to keep the heads with a person that makes the heads properly straight, and the arms will be properly straight and the leg will be properly straight, and the one of the those who will take the measurement, one of the measurement taker have to hold your ankles and give the feet flat against the foot piece. The feet will be flat against the foot piece, and then you will able to measure your height. So that is the measurement of height through the help of the infantometer when the child is lying down. That is ultimate, very important. When the child is lying down, in that way you will take the measurement. And when the child is like standing, that is on the stereometer scale. Again, the two hands will be there and the legs will be in a proper ankle length and the head will be properly straight. That is very important, and then only the headboard comes firmly to the headpiece. Okay. Now the thing is there, when you are standing, your back, your head back, your normal back, your buttocks and your calf muscle and your ankle, everything will be in one line. That is called line, and you are standing, you are just seeing the front line. So that is called line of sight. This is very important to be maintained while you are taking the measurement through the help of the stereometer scale. So that are the various measurement to be taken, and ultimately it is very important when you are in the OPD department, you have your own pediatric OPD in own chamber. You should know how to take the measurement with the infantometer, how to take the measurement with the stereometer, how to take the measurement with the weighing scale. That is need to be done properly. Now for the height also we are a formula up to 12 years we are using, not for adolescent. Same, because for the pediatric it's 12 years, not more than that. Then we come for adolescent. That is not pediatric. So for the pediatric Till 12 years, we go for weight formula. I have given weight formula are different. Now, height formula is 1, age in years into 6 plus 77. So, if I go for a 10 years, 10 into 6 plus 60. So, 60 plus 77, it's come under 137 centimeter. So, in that way, we are able to find the formula. So what you have to do, age in years, now I am just supposing a 10-year-old boy or a 10-year-old girl. 10 into 6, 60. 60 plus 77, that is 137 centimeter is the ultimate formula. So generally we know till 12 years there is no such energy requirement which is changed for boys and girls. So ultimately the height and weight expectations will be same as for boys as well as for girls. It will change after the adolescent, after the pediatric period, after the childhood. There is a change in from the adolescent time. So we go for this. Now there is head circumference. Whenever you take the measurement, the head is the child's head around its largest area, which is the ultimate big diameter. It measures the distance. It's above eyebrow and above ear and around the back of the head. You have to take the measurement. Okay, so that is very important. How you have to take the measurement. And same for the chest circumference. With the inch tape, place the tape and measure around the back and the front at the nipple level. And don't keep the measurement too tight or too loose. Take a proper way of measurement. That is the ultimate fittings. Now there is mid upper arm circumference. The mid upper arm circumference is measured from the left upper arm, this arm. This arm should be hang first of all freely, just like this, and the tape measured should be at the placed at the midden point of the upper arm. So it is between the tip of the acromion of scapula and olecranon of the ulna. This bones came middle may. This middle measurement is being taken as a MUAC. While measuring the mid upper arm circumference, there would be no cloth. There will be the bare hand. And do the recording of circumference. Then we plot it in the growth chart. So I hope the growth chart has already been properly explained by Shudrita ma'am. So then we are going to body mass index. So BMI, another very important thing. Generally, the criteria used to interpret the meaning of BMI under the number of children and teens are different from those used for adult. For children and teen, BMI, age and sex specific percentile are used for two reasons. First of all, how the body fat changes with the age first, and how the amount of body fat differ between the girls and boys. So, if the total amount it is less than 5th percentile, that is called underweight. 5th to 85th percentile is healthy weight. 85th to less than 95th is overweight. And 95th percentile से भी greater हो गया है BMI. What is the BMI value? उसका 5th percent is underweight, less than 5th percentile. 5th percentile से 85th percentile is healthy weight. 85th percentile से 95th percentile is overweight. And more than 95th percentile is considered as completely overweight. So that is all about how we take the measurement. Generally, BMI is not taken for the infants or children. Now we are coming to preterm nutrition. That is very, very important discussion to be taken. Premature birth in the worldwide health concern, where the earlier in the gestation babies are born, they are at high risk of death. Like there is already 9 months to 10 months of gestational period. If the baby born around 7 months or 8 months, of course they are at a high risk of death, serious disability and other health issues. And we are seeing that according around 15 million infants are born preterm everywhere. Okay, so according to World Health Organization, it is said that 15 million babies are born prematurely every year. And preterm birth is defined as a birth if there is not a completion of 37th week of pregnancy. Then what is the birth, that the birth of the baby before 37th week of pregnancy is ultimately known as a premature delivery. So who are the potential preterm birth complication? What are the birth complication the child may suffer from? Yes, the child may suffer from asthma, the child may suffer from intestinal disorder, infection, vision problem, hearing loss, dental problem, and sometime after after the elder days, learning and communication and behavioral changes. These problems are being identified for the preterm babies. So for the preterm care, what are the care? First and foremost, antenatal steroid injection that strengthen the preterm immune system and the lungs. First medical treatment. Then, after the baby is born, always given to the mother's womb. That's the mother's heat is very important. Skin to skin contact and frequent breastfeeding will regulate the heartbeat, breathing, body temperature maintenance in the child. That is called kangaroo care. Just like kangaroo is bearing its own children at the belly, just like that, if the mother is taking the child at the bare breast, that is ultimately called kangaroo care, which is very, very important for the preterm babies to recover more. Then we are giving antibiotics. Antibiotics can help to treat the newborn infections. A lot of children are suffering the intestinal infections, disorder, vision problem, asthma, and many more. So antibiotics can help to treat the newborn infection. And there is nutrition care. Preterm infants, first of all, preterm infants miss the intrauterine nutrient and ingest very small volume of milk. Therefore, they require an increased nutrient supplementation. A increased nutrient supplementation is very, very important. Now, there is preterm care improvement, decreasing the infant mortality rate. You can see that it is being with advancement of the practices, medical nutrition therapy, and the medicinal treatment, care, practice. The neonatal death rate per 1,000 live birth is England, and it has been decreased from like approximately 20 is there in 1960, which is 5 neonatal death per 1,000 live birth in 2010, and now it has been decreased also. But yes, there is a death rate which is there. So of course we have to take care about preterm nutrient. So what are the requirement of the children? So generally, external growth is linked to better brain development and long-term growth. Protein is important. Why? To support the growth and immune system. Carbohydrate gives us the energy for the child. So that is also another requirement. Fat helps with growth, energy, and absorption of vitamin A, D, E, K. That is also important. Nucleotides are important. It is supporting the immune system. So, of course, nucleotides are important. Calcium, phosphorus, vitamin D, that are important because it is very critical for the bone health. Vitamin E is a natural antioxidant. So, it is a nutrient that support the growth and protect the cell. A nutrient that supports the growth and protects cells. So, vitamin E is an antioxidant. That is also important. And lutein. Lutein is a antioxidant. Lutein, zeaxanthin, these are antioxidant, which is supporting the eye development and preventing the macular degeneration of the eyes. And there is DHA, arachidonic acid, and docosahexaenoic acid. For the brain development, the child needs this. So external development require carbohydrate, protein, fat. But internal development like organ, bones, vital system require various antioxidant, calcium, phosphorus, vitamin D, nucleotides, and many more. So the main motto is to increase head size, length to be increased, weight to be increased. That needs to be done. So preterm birth survivor had a high risk of growth and development disability rather than those who are the natural counterparts, who are the normal term babies, not preterm babies. So development of strategies to lower the complication of preterm birth from the rising need of the hour. They need a proper treatment. They need a proper nutritional need. So appropriate nutrition is very, very essential for the growth development of the preterm infant. Early administration of optimal nutrition to preterm birth survivor lower the risk of adverse health outcome and improve the cognition in the adulthood. So a group of neonatologists, pediatrician, nutrition expert, they convene to discuss and frame the evidence-based recommendation. So generally you have seen the picture in the first like preterm baby ka jo first picture I have given, the tube feeding. So generally the child is not able to suck properly. Their jaw has not fully developed. For that reason they need another feeding process. So enteral feeding process or tube feeding process is generally safe and may be preferred to parenteral nutrition, because parenteral nutrition can cause catheter related complication and many more. So generally we can go for tube feeding. But yes, Sometimes tube feeding is not ultimatum, so parenteral nutrition may be useful. Early, fast, or continuous enteral feeding yield better outcome compared to late, slow, or intermittent feeding, respectively. So, early, fast, or continuous enteral feeding yield the better outcome compared to late, slow, or intermittent feeding, respectively. Routine use of nasogastric tube is also not advisable. It is not like that everyday use nasogastric feeding. We should try to incorporate the oral feeding. But whenever the child born with preterm, we should start as early as possible the enteral feeding so that it may not be late. Preterm infant can be fed while on ventilator or continuous positive airway pressure with the support system, with the life support system. Also, they can be fed with enteral feeding. Routine evaluation of gastric residual, what is the level of gastric residual coming, or what is the level of abdominal problem, and how we can be avoid this, then it is routinely evaluation is there. And first and foremost choice for preterm nutrition is what? Breast milk. But the child cannot suck. What we can do? EBM. What is EBM? Express breast milk. So the mothers, from the mother's breast, the mother is expressing the breast milk into a sterilized bottle, and through this bottle we are giving this milk to the tube, and the child is getting that. Because this express breast milk have a huge beneficial impact in the cardiovascular, neurological, bone health, growth outcome. And then again, after this is the first choice, then we go for the second choice, that is pasteurized human milk. Pasteurized human milk means what is present in the milk bank. Milk bank is not generally present in West Bengal, but all over India, huge amount of milk bank is there. So which is containing the donor milk. We are giving the human milk fortifier without increasing the osmomolality. That is the milk from other mother, other, not from the child's own mother, from the other mother if the mother is not available, or if the mother has not sufficient breast milk. So then we go for the pasteurized from the other's mother's breast milk. It is being pasteurized. Of course, some amount of nutrient loss is there. That's why you give the HMF. HMF is human milk fortifier without increasing the concentration, meet the high protein requirement. Standard fortification is effective and safe, but it is not fulfilling the high protein needs what can be fulfilled with the help of breast milk. So generally we try to give the optimum nutrition through breast milk. If not possible, then only we go for options. Checking for optimal weight and sucking swallowing ability is essential prior to discharge for the preterm infant. Appropriate counseling, regular follow-up, monitoring after discharge will help to achieve better long-term health outcome. So this summary serves as a useful guide to clinician, address the challenge, and it's very important to provide the optimal nutrition. Basically, the preterm babies are low birth weight babies. So low birth weight babies to take a proper optimum nutrition is very important, because not only preterm babies are being deficient during their course of infancy, but they can also lead to be a preterm adults. So about 15 million preterm births are recorded each year in worldwide, and according to WHO, increase in the incidence of preterm birth over past 20 years in 62 of the 65 countries with the trending data. And we are seeing 1 million of the children die for preterm related complication annually, because preterm birth are the leading cause of newborn death, and second leading cause of death after pneumonia under the 5 year of children. So it is not only an adverse threat for that time, but also a threat for the lifetime and for the future one. And it has been seen during COVID at a case study that we have gone for a study and see that during COVID, those who have survived majorly are the full-term infant, but the preterm infant survival rate is lower than the preterm full-term infant. So ultimately, it is not only affecting the course of infancy or childhood; it can affect your whole life. So survivors of the preterm birth are at a higher risk of adverse developmental disability. They have a higher risk or rates of adverse health outcome in early adulthood. So rather than those who are the full term child. For them, it is like, although there has been improvement in overall mortality, but generally we can say that premature infants have a lot of other problems. What are their problems? First and foremost, neurological. Brain volume is decreased, neurological disabilities, situations or risk or proneness is more. Low insulin sensitivity, high blood pressure, intra-abdominal fat is high, metabolic complication risk are higher, increase the arterial stiffness, that is also there, and reduce the ventricular size and volume. So there is the blood pressure increasement. Lower BMD, bone mineral density is lower. That is another point of discussion. And there is increased risk of social disability in adulthood because they are not able to attain the proper educational level, income or establishment, because they have a preterm birth, preterm malnourishment, and that malnourishment is going on a vicious cycle and affecting the adult counterpart. They are also having malnourishment that will lead to impaired growth and development, lead to low income, and ultimately lead to the low education level, all over lead to poverty and going for the malnourishment again, and leading to the again to the premature delivery. And this is a vicious cycle. We have to break the cycle with proper nutrition. That is the ultimatum. With proper nutrition we can break this vicious cycle of poverty, and not only poverty, but along with a proper cycle of preterm nutrition and poverty. That cycle can be broken with the help of the proper food intake. So what are the feeding of preterm infants? How to feed? So generally we go for parenteral versus enteral. Enteral is much more preferred than parenteral, as the latter may be associated with catheter related complication, infection, sepsis, that is many more, and among the others. However the institutions of, just a second. However, basically the institution of early parenteral nutrition can be critical. So generally we go for enteral feeding or tube feeding. So the prevailing nutritional practice for preterm infant start to minimal 10 ml per kg body weight per day. Through the tube feeding we start. Okay, feed advancement we can increase it to 20 ml per kg per day. Then we start with amino acid, lipid, etc. So in that way we go for enteral nutrition options. What we can give: express breast milk, fortified express breast milk, and last but not the least option, formula milk feeding, which are called breast milk substitute or BMS. We can go for. Overall outcome: better feed tolerance, low risk sepsis, late onset sepsis, protective role in preventing retinopathy. As soon as possible we start the enteral feeding. It lowered the risk of hypertension, atherosclerosis, improved the ventricular volume, stroke volume, significant increase in the whole bone area, increase the BMG, and all over it increase the body's profile. Of course there is neurological development will be higher, IQ level will be higher, higher brain volume, white matter volume, matter microstructure will be increased, and all over our neurodevelopment, psychomotor, mental development is there, which will improve. Now there are consensus recommendation on the use of mother's milk for feeding the preterm infant. The first choice of human milk for feeding, already I have said, the mother's milk. If not possible, then go for donor pasteurized human milk. A pasteurizer should be used for pasteurization of human milk which is from the other mother. To know about is there HIV, HCV or hepatitis B, venereal disease, or any type of relevant disease is there. If not, then only others mother milk can be taken, pasteurized and given to the child. Donor human milk stored at -20 degrees for 6 months. Okay, preterm infant should not be fed anything before 3 months. Like any stored milk which is not more than 3 months can be given, but after 3 months we cannot be given. Which is stored for more than 3 months, we cannot be given to the preterm infant. It can be a source of infection. So generally, how much requirement is there? That is given by the European Society of Pediatric Gastroenterology, Hepatology and Nutrition. What has been said? That fluid should be given 135 to 200 ml per kg body weight per day. Energy to be given 100 to 135 kilocalorie per kg per day. Protein to be given 3.5 to 4.5 gram of protein per day. Fat to be given 4.8 to 6.6 gram per fat per day, per kg per day, sorry, per kg per day. What is the body weight? Accordingly that. Now carbohydrate to be given 11.6 to 13.2 per kg per day. Calcium 120 to 140 milligram per kg per day. Phosphate 60 to 90 milligram per kg per day. Vitamin D 800 to 1000 IU per kg per day. And vitamin A is 1300 to 3300 IU per kg per day, depending on the level of undernourishment. Is it a very low birth weight baby, or low birth weight baby, or mild malnourishment? And iron to be given 2 to 3 milligram of iron per kg per day. So that is the ultimate enteral nutrition profile which can be going for a preterm infant. That is the ultimate nutrition profile we can go for, and this chart should be followed for every time. Now we can go for human milk fortifier that can be called as a supplementation. So, human milk fortifier may be used only when the infant reaches a feed of 100 ml per kg per day. Based on this situation, we give the human milk fortifier. That is a sachet, 1 gram sachet. It can be used for 20 to 25 ml of express donor pasteurized milk depending on the product. It increases the protein intake, it increases the calorie intake, and in that way meet up the increased requirement of the infant. So generally the requirement of preterm infant is usually met with the addition of human milk fortifier, which give 4 gram per kg per day of protein and 3.5 to 4 gram per kg per day of fat. Of course, it is increasing the calorific value, protein value, and ultimately meet up the increased need for calorie, protein, fat. So higher protein, higher calorie strategy is very helpful to optimize nutrition. Calculation of protein intake while adding human milk fortifier and express breast milk help in simultaneous monitoring. There is no need to monitor and supplement additional calcium. Human milk fortifier has everything, so it can be given to the children with the express breast milk. So osmomolality is a key factor. Preterm formula can be used for preterm infant weighing less than 1.5 kg. Okay, not below that. And docosahexaenoic acid is a very important one for preterm formula. Everyone should go for that. Optimizing growth in the preterm infant lower the cardiovascular risk. So whenever there will be the faster weight gain in the preterm infant associated with risk of overweight and obesity, those who are taking more formula feed. So for that reason, ensuring the optimal weight gain, if it sees that weight gain is perfectly all right, then stop the formula feeding, go for the normal cow's milk. And there is also some post discharge recommendation. Ideal discharge weight of preterm infant dependent on several factors, and the sucking and swallowing ability is there. The child can take the food, or tube feeding. Tube feeding agar hoga to you cannot get the child out discharge. So you have to know that the child is having the sucking and swallowing ability, and also inability to feed, lethargy, temperature alteration, body may carbon dioxide concentration is increased, that cannot be, that require medical attention. This type of symptoms if there, you cannot discharge the child. First follow-up should be done within 3 to 7 days. Preterm infant should be monitored for minimum 2 years, preferably till adolescence. Those who are at formula milk, switch to standard formula when they reach the birth weight. Don't go for more formula milk or for more breast milk substitute, because it may lead to overweight situation. Complementary feeding may be initiated at the corrected age of 4 months. No special attention is required while initiating complementary feeding. No special attention is required, but complementary feeding for the preterm, we generally, when there is formula milk we are giving express breast milk, or when we are not giving breast milk, we are giving formula milk, then we can start the weaning from the 4 to 5 month onwards. Last but not the least, there is already what should give you for your baby. For baby's growth and development, nutrition is the ultimatum key. You can give the protein rich food. So not only always seafood, lean protein, poultry, egg, meat is important, but you can give the plant protein sources, bean, peas, legumes, lentils, soya product, unsalted nut seed, etc. Fruit is very important for vitamin mineral. Rather than fruit juice, we can go for whole fruit. Vegetables include a range of vegetables in the baby's diet. Fresh, canned, dried vegetables. Get a rainbow color vegetable, red, orange, purple, green, yellow vegetables every week. Get a rainbow color plate every day. That is very important. Cereals like brown rice, popcorn, quinoa, oat, wheat bread, that are the complementary one, but better to avoid the refined cereals and consume as less as possible. And fat free, low fat dairy product, milk, cheese, yogurt, curd, that are the best option to be taken. So an age wise diet chart I have given for a 2 to 3 year, 1000 to 1400 depend on the growth calorie. Dairy product 2 cup, fruit 1 to 1.5 cup, vegetable 1 to 1.5 gram, grain we can give 85 to 140 gram, protein 60 to 115 gram depending on the position. And 4 to 8 years there is calories, dairy product, fruit, vegetables, generally grains and protein. Protein requirement is high in boys rather than girls for 4 to 8 years. And for 9 to 13 years, same. The calorie requirement is high in boys and the protein requirement is also high in boys and grain requirement is high in boys rather than girls due to the muscle development. So that is the child. And for 14 to 18 years, same. The boys requirement, calorie requirement is higher and grain requirement and protein requirement is higher in boys than in girls. Same for the muscle development and of course due to the body composition, but they both require the same thing. That's all for today. Thank you so much everyone for attending the session. I hope I am able to give you some new insights about the preterm nutrition. Whatever the formula we use in the very generally in the hospital, whatever the formula we use and whatever the nutritional requirement we give to preterm infant, and in the OPD pediatric how we calculate the height, weight, MUSC and head circumference, chest circumference and proper way, that also I have given an idea about. Any question from today's session? Please raise your hand and feel free to ask me. So I just
very much nice class, ma'am. Here I am Shishi.
Yes, please.
Hello. Here I am Shishi, ma'am.
Okay.
It's a very nice class. Today the pediatric nutrition is a very important and is the briefly explained you. It is not previously I not intake from any parts. It is very fine, ma'am. Thank you, ma'am.
Thank you so much. Thank you.
Ma'am, I have a question.
Please.
যখন আমরা প্রিটার্ম বেবিদের জন্য ক্যালোরিটা কাউন্ট করব, তো ওখানে যখন ফর্মুলা মিল্ক ইউজ করব, তো ওখানে যে নিউট্রিটিভ ভ্যালু গুলো আছে সেখানটা দেখে ক্যালোরিটা কাউন্ট করব। তো
আমরা ওখানে প্রিটার্ম বেবির জন্য বলছো তো?
হ্যাঁ ম্যাম।
হ্যাঁ, অবশ্যই। That is the ultimatum which is given by the Pediatric Association. So we can calculate accordingly that per kg body weight.
Okay, ma'am. Thank you.
Okay. Any other questions? So yes, please.
Madam, actually, sorry. Actually, in case of excess of milk secretion, few mothers used to store it in their own fridge. Is that recommended or not?
Excessive milk secretion?
They are just storing in their own fridge.
Yes, they can. Yes,
household fridge.
They can can store their own fridge, but not the normal fridge storage can be done. That is a different freezer, different fridge you have to bring, because breast milk cannot be stored in a normal fridge. You have to buy a different small fridge is being basically they buy, and there they store, because breast milk take all those components which are present. Along with that, all the odor they will take, and it can contaminate it. So for that reason, there is a different small freezers which we bought for our gods. So that what we bought, this small type of freeze are available. Those are hand freezers, so that you can buy and kept store. So it's generally for 3 hours we can store, but not more than, generally we can go for 3 to 6 hours we can store it, and after that we can feed it to the baby, but not more than that. It is not recommended.
Is there any specific company named device for extracting milk, ma'am?
Yes, there are milk pumps. A lot of milk pumps are available. So there is no such company I can recommend, but I can say that you can buy the milk pumps, and these are available in the market. Those the breast milk pumps are available in the market, depending on the mother's breast size, that which will be convenient for the mother to express the milk. That is depending, and accordingly that we give that type of pump, because a lot of different pumps are available. So depending on the mother's breast size and the amount of milk they are secreting, depending on that the pumps are being chosen.
Okay, so there is no such product so far in the society which, with the extraction, they can protect the contamination or something like
No,
Tetra Pak
there
or
is
something like
no.
MST.
Ultimately for 6 hours we can go for, but after that we generally recommend no to the stored milk.
Okay, okay,
Yes.
understand. Thank you.
Okay. Okay. Thank you.
Hello, ma'am.
Yes, please.
Uh, Ma'am, I have a doubt. Like, there are so many patients who come and they ask us, like, their milk secretion is not too much to feed their baby. So, I just want to know how much ml of milk we can provide. We can tell to the patient that they can provide to their child when the child is growing, like it's first month
600
or
ml.
second month.
600 ml.
6 months. Okay. According to the month increases, so ml also increases, right?
Generally for the infancy we go for this, and after that the month increases, the milk secretion decreases basically, not increases. So it start
Oh.
from the, yes, milk secretion decreases, and that's why we start the complementary feeding. Nowadays we start the formula milk, because the generally mothers having the decreasement of the milk, and if the mother is having the express breast milk in a very proper way, then we can go for 520 ml to 600 ml is the ultimate requirement. And if the mother is able to express it properly, then we can go for 5 months, 6 months, there will be no issues. But generally we recommend to give it till 6 months, whatever the milk secretion is occurring, because the composition is changing.
Okay, ma'am, and also mothers usually ask a basic question like they ask what food should we eat basically available in their home so that they can increase their milk efficiency, producing efficiency.
So
So,
generally you can go for galactogogues. You can search those galactogogues. Those are containing, galactogogues are those food which are increasing the milk secretion. So along with that, nowadays mothers are also using the human milk fortifier. That in the breast milk, if you give one sachet of human milk fortifier, that will increase the protein content, fat content, calorie content, but not increasing the osmolarity or concentration. So that can also be given to the child, and that is also we are recommending human milk fortifier sachet.
okay, ma'am, thank you
Those
so much.
composition is, those mothers composition of breast milk is very lower. They are not able to feed the baby properly, the baby is not getting the proper food. For them we can give this
Mm.
human milk fortifier sachet, that
Ma'am,
can
that
be
is
efficient.
rich in protein. That is mainly rich in protein.
Rich in protein, rich in fat, and rich in calories as well. It is all over increasing the calorie, and it is very good for the those who are taking breast milk along with the human milk fortifier. So that's are
Oh,
available in the market.
okay, thank you so much, ma'am.
Ma'am, any company or brand,
I cannot name any
human milk?
company, but you
Yes.
can just you can go for human milk fortifier, and you can see a lot of human milk fortifier companies are there, because we cannot
Okay.
recommend the human milk fortifier company. It is by the doctor who will recommend the human milk fortifier company. We can only just suggest that you have to increase the human milk fortifier, and the doctor will recommend which human milk, the pediatrician will recommend that which HMF is required. Okay, any other questions? So have you liked both this?
Excuse me, madam. Actually, yes, madam. This 600 ml is for one serving or for
Yes,
madam? Excuse me.
yes.
This 600 ml would be a one serving or a day's dependent.
Our days, our days. How
This
can we
one
be?
serving, madam.
No, it's not one serving. It is for a complete day, and the child is not able to. The child is being given 20 ml, 30 ml, maximum 60 ml when the child is properly at a peak of the hunger. It's for the whole day. Per day, 520 to 600 ml milk.
So how many servings it should be, ma'am?
Milk secretion
Okay.
occurs.
So what is? Okay,
Yes.
ma'am, I understand. So
Yes, it's
this
occurs
six
milk secretion. If this is 520 ml to 600
ml.
ml,
Okay.
if it is 520 ml to 600 ml, then we can say the mother is secreting the milk properly. That is the ultimatum secretion. Some milk is not used, some milks we are just exploiting, some milk is being stored in the mother's breast. So accordingly, everything we can say 520 ml to 600 ml. That is the ultimatum milk production in a mother's breast in one day.
Okay, so in case of the mother is not secreting or otherwise the child is not able to suck properly, whether we should go for some other way of squeezing milk or a powder like content would be
Formula milk. Then we go for formula milk.
which one you suggest, madam? Whether it would be the
There are a lot
formula
of
milk only.
companies.
Okay.
There are a lot of companies of human breast milk substitute. You can go for any breast milk
Okay.
substitute. A lot of companies are there. So breast milk substitute, any one breast milk substitute you can go for.
Okay.
Yes.
So, in case of any special need, there is one child which I know is having excess of calcium by birth, so that its bones are so rigid and legs are stretched out.
No, this type of thing we generally don't give to pediatric patient, that they need extra calcium. Generally, if they are lactose intolerant or they are having any type of inborn error of metabolism, for only we give the extra, for on that we give the special formula milk. Otherwise, there is no such special formula for high protein, high calcium. We generally don't give to the child because it can cause constipation and many more other problems can be there.
Yes, madam. In future, I come across this constipation is there.
Yes,
And again,
will be there because
the
high
body
calcium
is
lead to calcium soap formation, lead to constipation. So ultimately, it will be there. So we generally do not recommend this.
okay. Okay.
Okay. Yes, Shagota.
না ম্যাম বলছিলাম যে এই ফর্টিফাইড যে এটা কি শুধু প্রিটার্ম বেবির ক্ষেত্রেই দেওয়া হয়?
এটা শুধু প্রিটার্ম বেবিজদের ক্ষেত্রে যে শুধু দেওয়া হচ্ছে তা নয়, যার মায়ের ব্রেস্ট মিল্কের সিক্রেশন ঠিক করে হচ্ছে না এবং ফর্মুলা মিল্ক চাইছে না, আমরা জেনারেলি ব্রেস্ট মিল্কই রাখার চেষ্টা করি, বাট when the breast milk is not able to meet up the needs, then only we go for, okay, you start with human milk fortifier, and if then the baby is perfectly all right, then we go with that, and if that is not also sufficient for the children, then we shift it to formula milk.
ওকে
Okay. Okay. Any other questions? Okay. Okay. Any other questions from anyone?
Ma'am, does human milk fortifiers cause any complication or something
Generally
to the
not.
baby?
Generally not. It is not. It is only for increasing the protein content and calorie content. So generally it doesn't cause any type of problem.
Okay, ma'am.
Okay. So I hope I have given everyone's answer. Thank you so much everyone for this interactive session, and I hope we will meet you again in any of the coming seminars or webinars organized by FST and Exploration Foundation, and I hope you like my class as you like my all others classes. So I hope you like my classes. So we'll meet you again. Thank you so much everyone. Good night. Have a nice day. Thank you.
Thank you, ma'am.